Welcome to Cardiology Pharmacy Part 3. The topics we're going to cover include angina pectoris agents, anticoagulating and antiplatelet agents, and then MI or myocardial infarction agents. So let's start with angina pectoris, or pain in the chest. So the pathology behind angina or angina begins with this pain behind the sternum, and it starts pretty rapidly. Usually it's caused by some kind of atherosclerosis from coronary artery disease, but at rest, the heart receives as much oxygen as needed for the contraction, and so there's a oxygen demand that meets oxygen supply, and so we can represent this by a scale, and this scale is even. There's no tipping of demand or no tipping of supply. When exerted, the heart needs to have more oxygen to be able to contract more, and a healthy heart increases the supply as needed. So the demand goes up, the supply goes up, no problem. The scales are still where they need to be. So this isn't a problem. Where we do have a problem is when the heart doesn't get the oxygen it wants, it causes a pain beneath the sternum. Sometimes this pain will radiate to the left shoulder and arm, and it will eventually reach the jaw. So when oxygen demand exceeds oxygen supply, and we have coronary artery disease in this exertion, then we have an imbalance. So we're going to look at the cardiac output factors, the preload, the afterload, the myocardial contraction, and the heart rate. So let's start with the preload. Again, that's how much blood in the left ventricle is there before contraction. The afterload is the squeeze required to push the blood into the aorta, so what's going on afterwards. The myocardial contraction is how powerful the squeeze is, and the heart rate is how fast the squeeze is. So the more the heart works, the more oxygen it needs. And treatment involves decreasing how much the heart needs to work or getting it more oxygen. So again, less demand, it needs less oxygen, or getting more oxygen, more supply. All angina types are caused by a lack of oxygen, and the treatments entail decreasing myocardial oxygen requirements. So if we're decreasing cardiac output, we can decrease oxygen demand. But let's first take a look at the classifications, or the three types of angina. There's chronic stable angina, which is exertional angina, and the cause is usually coronary artery disease, or CAD. There's variant angina, or vasospastic, literally a spastic vessel, and the cause is coronary artery spasm. And then there's unstable angina, where we have severe coronary artery disease with clots or blockage. That's unpredictable, and that's a medical emergency. So again, chronic stable, variant, or unstable. One medication that we can use are nitrates. So with chronic stable or variant, nitroglycerin, brand Nitrostat, causes vasodilation of the veins by directly acting on the vascular smooth muscle. The vasodilation decreases the preload, so if there's less preload, there's going to be less oxygen demand. Or the vasodilation can decrease the spasms, but it doesn't decrease the oxygen demand. What it does is it increases the oxygen supply. And you can imagine this, that when you have a vessel and it's spasming, it's obviously not a nice smooth flow of blood and oxygen. But when that spasm goes away, we get that smooth flow again. As we're looking at beta blockers, we see that with chronic stable angina, we can use propranolol, brand Inderal, metoprolol tartrate, which is low pressor, metoprolol succinate, Toprol XL, and we can decrease the heart rate and contractility. So the slower the heart rate and the weaker the pumping, the less work for the heart, and we cause decreased oxygen demand. Again, sometimes the compensatory reaction of the heart is to increase the heart rate to the point that it's difficult to fill, and if we can slow that heart rate, then we can create this lesser demand. With variant, we don't use beta blockers. They don't help at all with vasospasm. So when you're thinking about the variant, we're thinking, okay, well, maybe I can use a nitrate, or maybe I can use a calcium channel blocker, which is the next one we'll talk about. So diltiazem, brand-cardizem, or verapamil, brand-calin, both dilate the arterioles, decrease heart rate and contractility. So this results in decreased afterload. So less afterload is a decreased oxygen demand. If we want to think back to just basic physiology, where calcium is so important in muscle contraction, and by blocking that calcium, we're in a way decreasing the heart rate, decreasing that contractility because we affect it. We can also, with variant angina, induce relaxation of the spasms and cause an increased oxygen supply. So again, the two that work for variant are calcium channel blockers and nitro. And for chronic stable, we have calcium channel blockers, beta blockers, and nitro. Nitroglycerin can be given via different routes. Sublingual tablets, which is the most common and fastest outside of IV, works in about 3 minutes, and it's an oral spray. Transdermal patches as well, and then the adverse drug reactions. As you would expect, if you're going to rapidly vasodilate something, you can get orthostatic hypotension, and orthostatic quite literally means ortho, standing straight, static, in standing. So straight standing hypotension is a rapid loss of blood pressure, and then headache, again, from that vasodilation. The way that we deal with someone who's having a painful chest or having this angina and has to take a nitro pill is that if it doesn't go away after 5 minutes, take another tablet and call 911. The chest pain that doesn't respond to a nitrate may be an MI or a heart attack. Male patients cannot take nitrates with the PDE5 inhibitors. Those are the Viagra, Cialis, or sildenafil, as it were, due to the hypotension interaction. Okay, so now we move on to anticoagulants, antiplatelets, enoxaparin, heparin, warfarin, dabigatran, and clopidogrel. The coagulation cascade is something we're going to overview, but because it all kind of meets in one place, we're going to see how it's relatively straightforward as what we want to affect. The interaction between the different proteins or factors cause fibrin to be deposited at the tissue injury site. And the proteins have been named a long time ago, and they were named as Roman numerals. So factor VI is factor 6, and so forth. And they were numbered based on the discovery, not their function. So the cascade doesn't follow a numerical order, if you're wondering why it doesn't go 1, 2, 3 or something like that. And what we're doing is we're going from an inactive protein to an active protein, and we represent this by VII, so it'd be inactive protein 7 becomes active protein 7A. So as we look at the pathways, there's extrinsic and intrinsic, and the way that we measure them is by the prothrombin time for the extrinsic pathway, or the PTT for the intrinsic pathway. So what we're looking at is two different ways to get to this thrombin and fibrin, and what we want to look at is where do the medications that we use, what factors do they affect? So all these factors become targets for medications when we try to stop coagulation. PTT and PT become important when we want to monitor how well the anticoagulation is working. So warfarin, we see, is going to work on 9A, 10A, 7A, and then eventually thrombin 2A. Dabigatran goes right to 2A, and heparin, low molecular weight heparin 10A and thrombin 2A. So when we're looking at these, we're going to start linking all the pathways together, and we see the common middle, where factor 10A, or XA in the Roman numerals, links both pathways together and becomes an efficient way to stop coagulation. So anticoagulation, the vitamin K antagonists, Warfarin, brand Coumadin. It was developed as a rodenticide by Wisconsin Alumni Research Foundation, and you see WARF, W-A-R-F, which is the beginning of the name, in the 1950s. And rodenticide is something that kills rats. and it prevented the regeneration of vitamin K epoxide. Vitamin K used to create factors further down the cascade. It's used by factors 7A, 9A, 10A, and thrombin, which is 2A. It's a bit of a delayed onset, 5 to 7 days, and it's inappropriate for emergencies. So the dose changes take 7 to 14 days to take effect. Monitoring the INR, or International Normalized Ratio, that's a marker of time to coagulation. So most patients have an INR of 2 to 3. If we're lower than 2 to 3, we increase the dose. Or higher than 2 to 3, we decrease the dose. And obviously it depends on the patient, depends on the condition that we're trying to prevent. Adverse drug reactions: if we have high drug levels, we could have hemorrhage or bleeding, bruising, bloody stools, all of these different things. There are many interactions with warfarin, and we'll go over just a few with this pop-up. So green leafy vegetables have vitamin K, and this interacts with warfarin. And then several of the CYP450 enzymes work on warfarin as well. So a lot of drugs change the metabolism. So coumarin was discovered in cattle that died of hemorrhagic disease after eating spoiled sweet clover, and it was refined and developed into warfarin, is how we put this all together. Okay, well, that's warfarin in a nutshell. This is an oral anticoagulant. Let's look at something that's an IV anticoagulant. The heparins both inhibit factors 10A and thrombin 2A and are equally effective. There's unfractionated heparin, which is given by injection only, given in the hospital, and requires extensive monitoring. It's relatively cheap, but being in the hospital is not. Then there's low molecular weight heparin, LMWH, or enoxaparin, which is brand Lovenox. It's injection only, and it's given in the hospital and at home. There's no monitoring required. It's quite expensive, but not as expensive as being in the hospital. So the choice is to take someone from heparin in the hospital, both start with H, and then go on to enoxaparin. Now, as we look at the anticoagulants, and one of the newer ones, Dabigatran, brand Pradaxa, it's an oral direct thrombin inhibitor. It's quite expensive, but it doesn't require monitoring. We do have adverse drug reactions like hemorrhage and bleeding, bruising, bloody stools. And while it doesn't require monitoring, not having monitoring also says that we may not know how the patient is doing as well as if we did when we had warfarin. So the anticoagulants work on the coagulation cascade. Usually we're talking about the larger vessels. But if you're talking about a high-speed vessel, like an artery, arteriole, then we're talking about platelets. And the first antiplatelet we'll talk about is clopidogrel, brand Plavix. So glycoproteins 2B and 3A act as hands on the platelets, grabbing more and sticking them together. Clopidogrel prevents the hands from opening up, grabbing more platelets to form a clot. So what indications do we have? Well, myocardial infarction, or MI, cerebrovascular incident, percutaneous coronary intervention, and then the ADRs, just like with warfarin, just like with heparin, enoxaparin, and dabigatran, hemorrhage or bleeding are always possible. So looking at MI, or myocardial infarction, we're going to talk a little bit about this, and just a heart attack. So an infarct is tissue death due to the lack of oxygen. Coronary arteries supply the oxygen to the myocardial tissues. Blood flow stopped, usually by some kind of narrowing or blockage, and then the myocardial tissue stops receiving oxygen. So if the heart stops receiving oxygen, that's obviously a very bad thing for the patient. What we can see is that when we have this blockage, it's going to stop what's going distal to it, or what's going after the blockage, and that's going to be really, really difficult for the patient, because these vessels are very tiny, and we don't necessarily think of the heart giving blood to the body, but we forget that the blood still has to give blood to itself. So if it can't do that, then how does it pump the blood there? That's why a heart attack is such a concern. So the two types, ST elevated myocardial infarction, or STEMI, it's the more common, myocardial tissue death, and it releases cardiac troponins, 1 and T. These are the best markers to see if someone had a heart attack. and then the treatment we'll discuss next. The non-ST elevated myocardial infarction and STEMI is less common. The troponins are also released, but the ECG is going to show different rhythms. The treatment's not covered in this lecture. But let's look at what the elevated STEMI rhythm looks like next to a normal heart rhythm. So the elevated rhythm you're going to see here, and that's contrasted to the normal ST segment that we see here. So the ST segment is after the ventricles contract and are recharging electrically for the next contraction. So what do we do to treat an MI? Well, we used to have this acronym called MONA, where you have morphine for pain relief, oxygen to reduce the infarct size, nitroglycerin to decrease preload and afterload and to vasodilate, and then aspirin to be chewed to prevent platelet aggregation. But the guidelines are currently under review. They're going to be updated soon. But often beta blockers are used instead of nitroglycerin, slow down the heart, allow it to fill, because one of the responses of the heart is to start beating very fast because it's noticing that it's not getting oxygen to itself.